I had the possibility of giving this talk about, what is the current status of adult patient with BLL receiving CAR T-cell therapy. So one of the key aspects that were discussed in the talk is that today we have several CAR T-cell products which are approved for adult BLL. And despite some differences in the baseline characteristics, I would say that there are broadly comparable among trials regarding the median age, number of prior treatment lines, and proportion of prior exposure to allogeneic stem cell transplant and other targeted therapies. And these different drugs, brexucabtagene-autoleucel, obicabtagene-autoleucel, or also the point of care varnicabtagene-autoleucel, do have some differences also in the incidence and severity of CRS and ICANS, but in the end, we would say that the complete response rate is fairly comparable. It's around 70% plus, and also the median PFS, the median duration of response, is also around a year. So this might reflect that we might be reaching like a ceiling of the duration of the efficacy that might reflect the way that we are giving CAR T-cells right now, which is basically patients receiving therapy with overt hematological situations. So as you know, disease burden is one of the key drivers of efficacy, of the durability of response. Across products, almost all patients' responses is a very high response rate, above 70%, but patients will end up relapsing if receive CAR T-cells with very high tumor loads. So this might reflect that we might need to do something different. We might improve the way we select patients, especially patients with lower disease burdens. And also, it might also push us to do some things to improve outcomes with the drugs that we already have, not only treating patients with lower disease burden, but also improving lymphodepletion regimens, which is also something, a key driver in early expansion of CAR T cells.